mediastinal chest tubes and pleural chest tubes, because they're used for sort of two different functions in some senses, right? So after cardiac surgery, we put in chest drains to drain largely blood and fluid, and it's just blood. And the reason is because you're still in a closed space, and so you want to prevent cardiac tamponade, and you want to know if there's ongoing bleeding that might require something besides product resuscitation, because you have to heparinize people to a ridiculous degree and then reverse that in a short period of time, and sometimes it takes a while for the coagulopathy to resolve. So those drains that are in the mediastinum are really for collecting blood. The lung operation drains are both for blood and for air, and that's a different process, a little bit different pathophysiology that you're managing. So with respect to removing these drains, I think it's the easiest. I mean, you're not concerned about causing some kind of air leak or lung injury. There's less than 1% chance of causing some sort of tissue damage to what's next to it in terms of what the heart is, or bypass grafts. Those are the things that we worry about, because usually you have one tube that's on top of the pericardium if it's closed, or just on top of the heart if it's open. And sometimes that can lie next to a bypass graft, and that'd be the concern you'd have. The likelihood of you pulling a tube and causing a major injury is close to zero. That being said, it can happen, and it's on us in the OR to place them in a way where we don't think that's going to happen. In order to remove these, I don't think there's any real challenging or specific process. It's largely controlling the room and controlling how the patient feels, which is, anxiety medicine, a little bit of pain medicine, and appropriate positioning. A lot of people do it either laying down or just like a little bit, 30 degrees kind of in bed. And there is typically under the dressing some of these drain sponges occasionally, and a stitch that holds the tube in, which you guys kind of have here, which that needs to be cut. So the step one kind of thing is control the room, keep it calm, prepare the patient for what they're gonna experience, and usually that, in my hands, that discussion is, this takes less than 30 seconds. It feels funny, but it shouldn't hurt. It's a matter of setting expectations and getting comfortable, and once it's done, they're usually like, oh, well, that's not that bad, like, no big deal. So you come in, you have your dressing ready, whatever it is that you use. My thing about all this stuff is simplicity creates comfort for patients. If you have this whole show, it starts to build up the anxiety, and then people get worried, and then they're hyperventilating, and you're like, no, okay. So simple is best. So like a 4x4 and a tegaderm or paper tape that isn't painful. A lot of times the tape is like the worst part. It's been on, for a couple of days, and there's hair sometimes, and that can be the worst. Take off the dressing. You'll have a suture removal kit to cut the stitch, or a knife, whatever is there. These are, very basic scissors, no big deal. You cut the stitch. You have your dressing ready. If you have your gauze and your piece of tegaderm or whatever, and then it's just a pull. It's just a kind of a fast pull. This will be a little faster than that, but you want it to be smooth. You don't want it to be aggressive, because it might be lying close to vein grafts or something like that, and you just take it out. The exercise to discuss with the patients is their breathing pattern. 99% of that is just making them comfortable. And so what I always tell people, the other 1% is what would be considered like a Valsalva maneuver. And that's basically you get to a point of either maximal inspiration or expiration, and then a Valsalva, and that is intended to increase the interthoracic pressure and reduce the very, very, very already small chance of entraining air through an existing tube into the cavity from which you're removing the tube. I did a literature review to figure out what's in the textbooks about this. It's not very helpful. I did a recent literature review, and there's basically one okay-ish study about how to do this in terms of phasing it in the respiratory cycle. Either way you do it, whether it's at the peak inspiration or peak expiration, as long as you have a Valsalva, kind of a hold your breath moment, the likelihood of entraining air in any situation is far less than 1%. And that's what you want to avoid. So what I usually do is tell people to just take long, slow, deep breaths, and I'm watching them and I'm phasing their respiratory cycle so that they aren't thinking about it, and all they're doing is thinking about breathing. Take a really long, slow, deep breath in and out, and have them do it a couple times as you're kind of, taking the tape down and getting things set up. And then I'm looking at their breathing pattern when I'm getting ready to pull it. And when they get to a point where they're kind of valve-salving or holding, I just pull it. And then it's like, oh, that wasn't that bad. That's kind of my way of doing it. It sort of keeps them out of it. It just keeps them doing what they know to do, which is take a long, slow, deep breath. Everyone stays calm. They don't have to participate a lot, and you're done. The difference, with these tubes, again, you're not likely to entrain a bunch of air because you're not next to a lung that might have been injured during the operation. Occasionally you have lung injuries from like a mammary harvest, and you have I leave these tubes in on that side all the time, but not often. It's our job to tell you when it's safe to pull the tubes, whether we determine there's an air leak or some problem that we want to keep them in longer, not something that the bedside nurse should be concerned over. That should be, if the doc thinks that it's time, then it's okay. The difference, I guess, comes with respect to removing tubes in lung operations or operations where the lung could have been injured. And we're working on dealing with air and not just fluid. And that's why I have all these other fun toys to look at. With respect to the removal process, it's the same exact process. You just want to make sure you're watching them, timing their respiratory cycle, and doing it when they're either all the way inspired or all the way expired. I like to do it when they're inspired because I think that it makes the lung maximally inflated, and I think there's less likely chance to entrain air in addition to the Valsalva kind of pause. But there's no data for that. There's no evidence whatsoever. But if you're in their cycle, kind of timing them out, and you do the same kind of pull move, you have your dressing ready, you pull it. This will come out quicker because it's not silastic rubber. You have your dressing ready, you put your tape down, and then they keep breathing the same way they were, and you're done. If there is, so things to watch out for was something that kind of came up. If there is a problem, it's going to happen in the first 30 minutes or an hour or so, and the things you're going to see are an increase in pleuritic chest pain, sometimes diaphoresis, you're going to have some desaturations, you're going to have just general discomfort. Somebody will say, I don't feel good, I can't get a good breath. I can't get a good breath. And that's when you put your pulse ox on, you check their sats, you call the doc, and you get an x-ray, and then you decide what to do. The other I kind of end down the road complication that can happen if you've got somebody who's really hypoxic is they can get bradycardic. The likelihood of that happening from a chest tube removal is very, very small, but it could happen. That's kind of down the line. What do we do if we see somebody that has increased pain, shortness of breath, a little bit of desaturations, and you're waiting on the x-ray, and you call the doc? So what would we think to do? What's the problem?
Oxygen.
Yeah, so what do we do to treat that? So you put oxygen on, and you set up likely for another chest tube. And that is to say, hey, the lung probably collapsed and this person doesn't have a lot of pulmonary reserve, so you put a tube back in and you deal with it. A lot of times in 2024, that's going to be go down to interventional radiology and get an image-guided tube to avoid all the trauma of having another tube in at the bedside, because you don't need to do that. The trauma docs have a different scenario. Things are happening all at once and they can't move anybody, but in a controlled setting in a post-operative patient, you're most often just going to go down to radiology or do it at the bedside with an ultrasound, which is something we used to do a lot. I see that less now. It's more radiology driven. What else?
On the chest tube removals.
Yeah.
on the mediastinal tubes?
Yes.
Both at the same time or one at a time?
So good question. A lot of times the OR will come out with sort of a Y-connected sequence here, and it's very surgeon-driven, surgeon-specific, and also materials-driven, because you'll find that there's all these different connectors, and some people don't have the right ones, or we are out of this one, or there's different caliber tubes, and they have to go into the same drainage container. For my folks, I'm gonna have the mediastinal tubes wide together in the same pleurovac, and so they would come out together.
Okay, but we don't have to like pull one, hold pressure, pull the other one. We
No,
can pull both.
you can have two people pull them at the same time. You can, it shouldn't be any higher risk to do one at one and one or two at the same time. I mean, just, that's not the technical point. The technical point is really just keeping the patient calm, and if that means you do one at a time and prep them for that, fine, not a problem. My hearts, when I have a pleural drain in place, it's typically because I harvested a mammary, and when I do those, I usually open the back of the pericardium to let fluid drain into the pleural space. So I keep that a little bit longer, and I remove that a little bit later, because they're generally better tolerated than the mediastinal tubes, because there's just more space and it's a little less discomfort. Usually the discomfort you get is right at the back of the shoulder, because the tube's up there sitting there, and that's the referred pain kind of pattern for people. These are kind of like funny because it's right there, and you feel it on every heartbeat, and people find that sort of moderately uncomfortable just to have those tubes in place. There is a wide variety of when people decide to remove pacing wires and how they sew them in. I have been at institutions where the practice was to remove the pacing wires and get an echo at the bedside within the next 30 to 45 minutes to make sure that there's no bleeding. And that has more to do with how they're sewn in than how they're removed. Because if they come on needles, so we sew them into the ventricular tissue. I mean, they're sewn in. But if you do it in a deeper bite, you can have a bigger problem. My practice is probably going to be largely that they get removed, assuming it's clinically appropriate, meaning we're not having dysrhythmias or any concerns from a cardiac function standpoint. They're going to be removed on a day that's either the same day or right around the day we remove the chest tubes, before discharge. And that's because I know that if I didn't have to do anything extra to secure them, then I'm not real worried about you pulling them, because I know that they're kind of, it's like a thin bite, and a lot of times they're not even really sewn in anymore. They're just right under the ventricle, right on top of the diaphragm. And I don't use a lot of arterial or atrial wires. Some surgeons do use both, some don't. I try to do as little as possible because I don't want the problems, as long as it's safe enough when we need to use the wires for pacing management. And the process for pulling wires is very much the same. I mean, you want to disconnect everything because you don't want the weight of it. You don't want to have some RNT or some weird phenomenon that you don't want to deal with. But it's really just getting your dressing ready, and then it's just a gentle pull. If you feel resistance, you stop. If you feel like you can pull it all the way, you pull it all the way. If you really don't feel like it's coming because it's sometimes sewn in extra, you pull it all the way out to whatever skin level you can get where you get resistance, and then you just clip it, and you can just cut it. They're not dangerous. There's a very, very small chance that if they went through a prolonged energy source like an MRI, that you can get heating of them, and that can cause internal injury, and that's what people worry about with leaving wires in. But it's risk benefit. If you're like, hey, these are sewn in, and if I pull this out and it's going to cause bleeding, I don't feel comfortable, and we're doing okay, it's more benefit to leave them there and deal with that very small probability of some other future problem than it is to take the risk of having to go back for a sternotomy just for pacing wires, which we've all done. It definitely happens. There's, I guess the point to make is that there's really no like technical extreme skill involved in this. It's just a comfort and a knowledge of what you're dealing with, and a, you know, bedside nursing skill set ability to make the patient comfortable. I mean, that's a number one, and that's what nurses do. That's what nurses are best at. And that's why I think that I want all the nurses here to be able to be comfortable with this skill, because that's how patient care, I think, is best driven. What